Hi, welcome. Today, let's review DMARDs, or disease-modifying antirheumatic drug therapy. We use DMARDs every day in the world of rheumatology, so let's define what it is first. A lot of rheumatic disorders have no cure, so as rheumatologists, we aim to bring the disease into remission. So drugs that have the abilities to do this are known as DMARDs, and as the name suggests, they modify diseases. Also, for a medication to be considered a DMARD, the effect should change the course of the disease for at least 1 year, and it should be evidenced by either sustained physical function improvement, decreased novitis, or slowing or prevention of joint damage. Today we'll go over 9 drugs, and I'll give you quick important pointers for your board studying and clinical practice. Again, this is not a comprehensive review, so just use this as a guide. Also, some of the drugs are used more than others, but I think you'll still be asked about them during training, so I hope this review will help you prepare and answer them. First drug category we'll cover today is antimalarials, with Plaquenil being the most frequently used antimalarial. In terms of mechanism of action, there's a lot of mechanism of action for this drug, but disruption of binding of RNA or DNA to toll-like receptors is something you should remember. Retinal toxicity is very big when it comes to antimalarials. So the risk of retinal toxicity is dose dependent. So try to keep it under 5 mg per kilogram. And if a patient is on a drug like tamoxifen, that's a double whammy because tamoxifen itself is a toxin for the retina. You want to recommend patients to get their eye exam prior to starting the medication as a baseline. And usually I tell my patients to notify the eye doctor that they will be placed on Plaquenil, so the ophthalmologist is also aware. After 5 years of use, patients should get yearly checkup. So they should get the eye check during the first year and then yearly after 5 years. That's like the textbook answer, but most patients that I've seen usually get eye exams yearly anyway, like their annual physical exam. G6PD testing is important as there's concerns for hemolysis. One good thing about Plaquenil is that it can lower lipid level, prevent diabetes, and blood clot. You can see why Plaquenil is used for antiphospholipid syndromes now. Second, we have sulfasalazine. Sulfasalazine is a medication that we do not understand the actual mechanism of action, but we know that it is broken down by gut bacteria to 2 components: sulfapyridine, which has antimicrobial property, and aminosalicylic acid with anti-inflammatory effect. If a patient is without his or her colon, it makes sense that this would not be a good choice. Side effects to remember is azoospermia for men, agranulocytosis, and rash. Azoospermia is reversible within 3 months of cessation, and rash and agranulocytosis is most prevalent during the first 3 months of drug use. Sulfasalazine also needs G6PD check. Next, we have methotrexate, and I'm excited to share these tips for methotrexate. This is probably one of the most commonly and most effectively used drug for rheumatoid arthritis patients. First things first, who should not get methotrexate if this is such a good drug? Methotrexate is a category X drug, meaning childbearing females you have to be careful with if you're thinking about using methotrexate, and try to avoid them if possible. If a woman is on methotrexate and they want to conceive, you need to tell them to wait at least 3 months before conception. This also goes for men. Methotrexate can affect the liver, so if someone has history of Hep B or Hep C, they need to speak to liver specialists first. Also, because it could affect the liver, you need to tell the patients to limit their alcohol use. Methotrexate can give side effects like oral ulcers, and it is given with daily folic acid, 1 mg per day. However, let's say a patient has mouth sores and is not getting better, folinic acid or leucovorin 5 mg can be used as well. And if you decide to use the leucovorin, remember that you want to give it 24 hours after a weekly dose of methotrexate. Methotrexate, by the way, is always a weekly dose medication. When patients get hospitalized, sometimes their drug list gets mistakenly updated as methotrexate daily dosing, which hopefully will be flagged by the system. But just remember, methotrexate is always a weekly dosing. However, I don't want you to get confused with split dosing. So we use split dosing for methotrexate because, generally speaking, patients will be on methotrexate from 7.5 milligrams weekly to 25 milligrams weekly. After a while, so as the dose of medication is increased, absorption will be decreased. So you could potentially split the dose. So let's say patient is on 20 milligrams weekly, and you want to give 10 milligrams on Wednesday night, and they could take 10 milligrams on Thursday morning, and something like this. But you'll never split the dose to make it a daily dosing. In terms of bioavailability, sub-Q methotrexate can improve bioavailability as well, and that's something you need to remember. You may see patients with EBV lymphoma while on methotrexate. In that case, if you stop methotrexate, it may actually resolve. Methotrexate has a long half-life, and it may be good to know that that is due to the fact that medication inside the cell gets polyglutenated, and once it's polyglutenated, the medication cannot leave the cell, so methotrexate remains intracellular. Next, we have leflunomide. It's another category X teratogen medication. Leflunomide is a good option for patients who cannot take methotrexate due to lower kidney function. But remember, leflunomide also gets metabolized by the liver and GI tract, so be careful when other hepatotoxic agents are going to be used, or if patients are already with hepatic impairment, then you should not use leflunomide. We talked about a long half-life for methotrexate, right? But if you think methotrexate has a long half-life, leflunomide has extremely long half-life. In some cases, it could even stay in the system up to 2 years. So in case someone overdoses on this drug, or if someone is pregnant, they just find out that they're pregnant while on leflunomide, you have to know how to eliminate the active metabolite. You are going to rescue them with a medication called cholestyramine. You will need to check the blood level of active metabolite on 2 occasions 14 days apart after the rescue therapy. By the way, if you hear the term A771726, that's talking about the active metabolite of leflunomide called teriflunomide. This metabolite inhibits dihydroorotate dehydrogenase. And yes, you need to know the name for your boards. Oh, and one side effect, or it could actually be a pro for many patients, is the associated weight loss with leflunomide. However, not everyone wants to lose weight. So if you have frail elderly patient who's actually trying to gain weight, leflunomide is probably not the best option. Let's talk about minocycline. Who would be a good candidate for minocycline? If someone has frequent infections, this may actually be a good option. If someone doesn't want a lot of blood work, minocycline is also a good option. The efficacy mostly has been demonstrated in seropositive patients for rheumatoid arthritis, so that is a good cohort of patients to use minocycline in. One notable side effect is hyperpigmentation of the skin, which can be pretty significant. Actually, I highly recommend you go to ACR Image Bank and checking out minocycline hyperpigmentation pictures. They're pretty remarkable. And if you see, you'll see that hyperpigmentation is not limited to the skin, but it could affect your nail bed and your sclera as well. Minocycline is one of the medications that can induce lupus with DNA antibodies and also p-ANCA, although the probability of minocycline-induced lupus is pretty low. So can we combine medications? Can we combine DMARDs? And the short answer is yes. And usually when you talk about combination therapy, you will see that methotrexate is included in the combo therapy. So you could use methotrexate with plaquenil, or if you add sulfasalazine to that combo, so methotrexate, plaquenil, and sulfasalazine, that will actually make it a triple therapy. And at this point, I have to mention about Rocket trial. This is something you must know. Triple therapy, let's back up and let me give you a scenario. Let's say you have a patient with active disease, active rheumatoid arthritis. Patient is on monotherapy and the patient just doesn't seem to get better. At that point, would you start TNF-alpha inhibitor? Or do you think you could go with a combination of DMARDs or a triple therapy? Well, Roquette trial answered that question. So the trial actually showed that the triple therapy was non-inferior to etanercept plus methotrexate in patients with RA who had active disease despite methotrexate therapy. So the next time you see a patient with rheumatoid arthritis not being controlled by methotrexate, know that there are more options than just jumping to the biologics. Methotrexate can be combined with Imuran or biologics as well. And when I say biologics, I mean all of the TNF inhibitors and rituximab. And you may wonder why methotrexate is always included in the combo therapy and why it's good to be used with biologics. There's a strong evidence that methotrexate improves efficacy of other medications like other DMARDs, TNF inhibitors, or rituximab. And in the case of biologics, this may be due to the fact that methotrexate has protection against anti-drug antibodies. But remember that to have that protection against ADA, methotrexate dose have to be 12.5 milligrams weekly or higher. So let me just go over a couple of medications that are not too commonly used but still important to mention. We have dapsone. So when you see dapsone, you're going to think about skin. Dapsone is an anti-parasitic medication that is also a folate antagonist. It was used for skin conditions like leprosy or Hansen disease, but it has anti-inflammatory effect, which is the reason why we use it in rheumatic conditions. But which rheumatic conditions? Mostly we're going to use for skin vasculitis like LCV, urticarial vasculitis, erythema elevatum diatinum, or cutaneous PAN. Also, there may be additional potential here for skin lesions of Behçet's, lupus rashes like bullous diseases or paniculitis, relapsing polychondritis, or pyoderma gangrenosum. Interesting fact, dapsone is used for PCP prophylaxis for patients who are allergic to sulfa antibiotics, so like they cannot use Bactrim, so they may opt to use dapsone. Next, I have thalidomide. It's an uncommon medication, but it can be very effective. It works by reducing TNF-alpha production. Side effects of thalidomide are very important. It's a teratogenic medication with devastating outcome of phocomelia. If you remember from your medical school days, it's a condition where babies will be born with shortened limbs. And you can see how that could be very devastating. So patients, if they are going to be started on thalidomide, you cannot just give it. You have to register them, and they're going to have very stringent regulations, and you're going to have follow-up with the patient on a regular basis. It's required before they could get the medication. And VTE risk is always listed as black box warning for this medication. Polyneuropathy is also very important. So polyneuropathy can be progressive and non-reversible. So baseline EMG will be ordered with regular follow-up EMGs, but you're not going to just go by the EMG report. You're going to follow up with patients, and if patients have even subjective complaint of numbness, that is good enough reason to stop the medications right away, even with confirmation with EMG that there is something wrong. Lenalidomide works similarly with thalidomide, but it's got less side effects like blood clots or sensory polyneuropathy. Lenalidomide, the major side effect will be thrombocytopenia. So let's recap. From the medications we discussed today, Plaquenil, sulfasalazine, and dapsone will need G6PD checks before starting the medications. Methotrexate and dapsone will need daily folate consumption. Methotrexate, leflunomide, thalidomide are teratogens, and you need to be very cautious. Leflunomide, due to extremely long half-life, will need cholestyramine rescue if patient overdoses or if the patient gets pregnant. What I went over today are high-yield information, but again, not a comprehensive review. So please do your own studies. There's a lot of important drug-drug interactions and other side effects that I did not get to mention here. And as always, good luck to you all, and hope to see you next time. Bye-bye.